Thank you. Yes, so we'll have our first abstract presentation by Dr. Hashamizadeh. He's from the University of Utah and will be speaking about automated 3D localization and segmentation of carotid arteries in black blood vessel wall imaging.
Good afternoon. My name is Kazem Hashemi. I'm a data scientist with the Radiology Department, University of Utah. And today I will be talking about the automated 3D localization and segmentation of carotid arteries in black blood vessel wall imaging data. So as you know, carotid arteries are susceptible to atherosclerosis, and atherosclerosis is one of the major sources of ischemic stroke. So the clinical importance of vessel wall imaging for carotid arteries is very obvious. Actually, vessel wall imaging, magnetic MR vessel wall imaging with black blood contrast is an effective imaging tool to image normal and diseased artery to identify the stages of the atherosclerosis, the status of that disease. With advancement of the imaging techniques, like high resolution 3D vessel wall imaging data of carotid arteries are now available, and that makes the automated analysis of this increased amount of imaging data a necessity. So in this work, actually, we are presenting a framework, AI deep learning-based framework, to do the very first step of image analysis for black blood vessel wall imaging data. And this framework is designed as when a human reviewer wants to actually segment the carotid artery from the imaging data. That is typically we find the bifurcation first, and then we trace the lumen to localize the carotid arteries, and after that we are able to do the outer wall segmentation. So the imaging data that was used for training and testing this framework are from three data sets: CARE2 data set and IPH cohort and RANGI data set. So CARE2 and the IPH cohort, the vessel wall imaging data were acquired using 3D merge sequence, and for the RANGI data set, the 3D VISTA acquisition was used. In total, we had 138 subjects, and the ground truth segmentation were generated using a semi-manual labeling using an active learning strategy, meaning that the labels were generated by AI algorithm, then corrected in a few rounds to make and retrain the networks again. And the software were ITK Snap and 2D Cascade at different stages, and you see some of those data here in these slides. So the very first step in this framework is the bifurcation detection. We use a modified 3D SonoNet architecture for the bifurcation detection. And this network is fully convolutional in the superior-inferior direction and generates two scores corresponding to the to the absence or presence of left and right bifurcation in the axial slices. So here actually we have a showcase for the output of the network for a testing case. On the left you see the prediction of the network and the location of the bifurcation of the left and right carotid. And on the right you see the activation maps of this bifurcation detection network. And you can see the network actually by looking at the activation map you are able to verify that the network is looking at a relevant feature to do the bifurcation detection. And here is the statistical ROC analysis of a bifurcation detection network. As you can see, the area under the curve detection of one bifurcation is 95%, and since we have two bifurcations, so in general, this is a very good accuracy when we take into account the other bifurcation that we want to detect. So after the bifurcation detection, we are able to extract the region of interest for, or a 3D bounding box around the bifurcation to do the lumen localization of the carotid arteries. And for that goal, we are using a 3D unit, and this unit has been trained using three different loss functions, including binary cross entropy loss and Euclidean's distance transform using Euclidean distance, and also a 3D canvas active contour loss. So the last loss is a actually is an unsupervised loss function and doesn't require any labeling data. So and here you see the results for three test subjects, and the average DICE score for lumen localization using this network is around 92%, which is a very good performance for localization purpose. So after localizing the lumens, we are able to extract 2D patches around the lumen of the arteries, and then we are able to do this fine segmentation of the lumen and outer wall. So we use a novel network, we call it O-net, as the shape is like an O, like a unit that has that has been completed by the upper part, as you can see in this slide. And from the structure, actually the structure is that the overall structure is using two of this network. The first network does the lumen segmentation, then the results of lumen segmentation along with the original images are fed to the second network for the outer wall segmentation. So this network actually achieves a DICE score of 94% for the lumen and 91 for the outer wall, and which is a pretty good actually segmentation performance. And here you can see the segmentation results for three test subjects. Showcases the results. And you can see that actually the network is able to handle different shape of the lumens and outer wall, not only the regular arteries, but also in the bifurcation area, which is the most challenging part to do the segmentation. So when the segmentation actually done, it enables a lot of analysis, and here I'm showcasing one of those analyses that is very typical, and it's the wall thickness measurement. So here we use a 3D wall thickness measurement technique using Laplacian method, and to actually measure the wall thickness without any ambiguity. So the technique is based on solving the Laplacian equation for a potential field that is between the lumen and the outer wall, and that potential field actually gradually changes from 0 in the lumen to 1 in the outer wall area. And using that equation, actually we are able to have those sublayers, and by adding up the distance between those sublayers and actually measuring the length of those trajectories, we are able to measure the thickness. And so this technique actually enables not only to measure the thickness, but also proximity to the lumen and outer wall for all given pixels and voxels. And here is an example of that wall thickness measurement. Actually, we can do the thickness measurement and represent the results as a map, 3D map, as you can see, because we are able to do the thickness measurement in all voxels. Also on the right, you can see we are also able to actually report that thickness measurement as a function of the surface of the lumen to illustrate the areas that we have a thicker wall compared to the normal wall, as you can see in that heat map. So in conclusion, actually we present a framework that offers a robust segmentation, localization, and segmentation of carotid arteries. Compared to previous works, this is more 3D based, multiple data sets have been used, and also this generalizes better compared to our previous framework that we have dealt with. And for the future work, there are lots of future works that is ongoing and also need to be done. One is we are generating a lot of data, actually summarizing those data in a structured and concise way, and also extending this framework for multi-contrast vessel wall image analysis is going to be another future direction that needs to be done. Thank you for your attention, and with that I'm open for questions.
Are there any quick questions? If not, just in the interest of time, I think we'll move on to the next abstract,
Thank you.
but thank you. So great, next we have Yin Guo from the University of Washington, who will be talking about a unified plaque composition segmentation framework with flexible combinations of multi-contrast carotid VWI.
Hi everyone, this is Yin Guo from Vascular Imaging Lab, University of Washington. And I'm glad to see actually some of these functionalities of plaque analysis has already been achieved by like United Imaging talk just now or the TS Imaging talk yesterday. But I hope my presentation today can inspire some new ideas of how we can build the model better. As we all know, cerebral vascular disease is a top death cause worldwide, and especially carotid atherosclerosis contributes to ischemic strokes in a lot of scenarios. For example, like the growth of the atherosclerotic plaque may increases its risk of rupture, and it will also narrow the lumen and causes the reduction of distal flow. MRI has been used and through very extensive histological validation to be able to characterize the lumen and also the vessel wall very well. And the overall goal is to identify the features that may link to plaque instability. And using MRI, we can even appreciate the plaque that did not show significant stenosis on the TOF MRI. I'm talking about multi-contrast vessel wall MRI. So as an example showing here, analysis of 2D multi-contrast vessel wall MRI provides us with extensive information, both about the plaque burden, that is showing in this blue and red contours that can detailing the lumen and outer wall of boundary of the plaque, and also the plaque tissue composition. Like many of these are high-risk features identified, like intraplaque hemorrhage, which is proved to associate with increased risk of stroke. So in order to help facilitate this extensive analysis of multi-slice, multi-contrast vessel wall imaging, we're trying to use artificial intelligence to facilitate this process and also to quantify plaque burden and the composition at the same time. So there are a few previous works that reported in this fashion that we will always use a structural images like T1 weighted images to do a segmentation of the wall. And so this is, sometimes it's a standalone project. And then we use the segmented vessel wall mask and combine that with other contrasts to derive a more detailed composition max that can quantify those high-risk plaque features. My work, it's called CAPU, so it's aimed to improve the reliability and also the flexibility of the previous workflow that I mentioned. First is that this workflow is kind of 2 stages segmentation. So in order to achieve a good segment result on the second stage, that is the compositional stage, we need a good segmentation on the first stage, that is to get a good vessel wall segmentation. In this work, I'm trying to combine the 2 stages together based on this constraint of vessel wall prior and consistency loss. And then I think in this generic model, we simply just concatenate the multi-contrast image information at the input stage of the network. But I think we can more efficiently utilize the information from multi-contrast images. So I would design a network that can do this, better do this cross-contrast feature fusion. And in terms of the flexibility, as we all know, most networks require during the test time, it requires the identical input as the training set. But in the real world practice, sometimes there will be more contrast than the training set, or there will be missing contrast or bad imaging quality. And instead of, besides T1, T2, and TOF, these are normal, widely used contrasts, they are also proton density weighted and contrast enhanced T1 weighted and MP-rage. Sometimes contrast enhanced T1 weighted image may not be available during the scan, during the clinical practice, patients, they have issue with the contrast ingredient, and also the MP-rage, sometimes the image quality would be quite bad. So I'm going to introduce a unified model that can be trained on these different combinations of this contrast, and it can also be, during test time, we can use one model to accommodate all these different scenarios. So I will introduce this cross-contrast feature fusion. So we'll have for each contrast, we'll have a separate encoder, and we'll have some decoders that can be used for segment different composition. And we use mainly the max operation and the skip connection to do the contrast fusion. So for each UNet multi-layer feature, for all the other contrasts, we take a max at each layer, and then we skipped connect together with the T1 encoder. So we can get a T1, so the input to each layer T1 weighted hemorrhage decoder is the T1 weighted encoder at that layer, and the max of all the information from all the other contrasts. So in this fashion, we can combine the information at each level rather than the input level. And as I said, I want to combine the two steps together. So we still use a generic UNet to segment the vessel wall based on T1 and TOF images, but then we will, during the second step segmentation, we will also use a consistency loss that will try to make the network learn to segment the vessel wall again, and learn the vessel wall and also the composition at the same time, and using the two results from this two segmentation neural network, derive a consistency loss to better combine the two processes together. And the third is a topological constraints. As we all know, this hemorrhage is always reside inside the lipid-rich necrotic core. So the design of this loss function is just to explicitly enforce this restriction, where there is when in the ground truth there is lipid-rich necrotic core. And it's better there when the ground truth there is hemorrhage. It's better there be necrotic core too, or if there is no necrotic core, then you'd better not segment hemorrhage there. So it's an explicit enforcement of this relation. And in the end, we are trying to, this is an overall structure of the model. So we have, as I said, we have separate encoder for each contrast, and based on their clinical use in delineating the composition, we have one or multiple decoder for each contrast, and then the feature fusion model is in the model. So during the experiments, we test a few different scenarios as a configuration. We consider the space model as the minimum requirement of the contrast needed to perform the task, and the full model that's also added contrast enhanced T1 and also MP-rage. And in the end, we also train a unified model that this model can be trained you can randomly select the availability of the contrast and then do the segmentation. Yeah, so I will just briefly show some results of the dye similarity coefficient. So we compared this both CAPU base and CAPU full model with NUNet, and I think they are showing very comparable performance. But in terms of this mixed model, this unified model, I don't think NUNet support this flexibility of input, but we can still get a very reasonable results given like multiple combination of the input. So, and there's an external test set. We are trying to validate these results on many other like external data sets. So as we can see, either we input 4 contrasts or we input 3 contrasts into this network. It can also, the CAPU can derive quite reasonable results. Oh, where's my conclusions? Yeah, sorry. And in conclusion, we propose this a more flexible, a unified framework that I think can better help the model to be deployed in a real-world setting where we don't need a two-step segmentation, and where sometimes some modality, some sequence may not be available. Yeah, and we are still trying to validate this model in a more diverse data set and also 3D imaging. Yeah, thank you.
This abstract is now open for any questions.
I have a quick question, actually, here on stage. Very nice work, very impressive results. I was wondering, because the multi-contrast scans are acquired separately, in many cases there may be a slight mismatch between the images, particularly on pixel level, due to patient motion. Have you taken it into account of that in your approach, and is that still a challenge, or do you think that's something you can overcome?
Yes, I think I'm also trying to develop a separate model specifically for the registration. So I think for now, CAPU assumes that all the images are already like well registered to derive the results. But I think in the future, if we can have a model that can combining registration and segmentation at the same time, it will be even better.
And I have a question regarding calcium in the vessel wall. We are waiting so hard for seeing calcium like we see it in CT because of curing the carotid artery includes stent placement, and we have different stents, self-expanding ones and balloon expanding, and to choose the right stent or the right operation method, we need to know the calcium amount, and we want to see it with this picture like CT. Until now, we have to do for this question on CT.
Yeah, I think it's raised a very good question. I think this black blood vessel wall sequence has its limitation in detecting calcium because I think it's also very low signal, and I think maybe we need a better sequence, like dedicated sequence development to first to identify calcium better, or you can try some transfer learning approach maybe in AI to learn from experience in identifying calcium in CT and transfer that knowledge into MR. I think that would also be helpful. Thank you.
Great, thank you so much, Ian. Next, we'll have Patrick Winter from the University of Greifswald, who will be speaking about automatic segmentation of senosed intracranial arteries from 4D flow and convolutional neural networks.
Hello, thank you very much for the attention. I'm a postdoc at the University of Greifswald at the wonderful Baltic Sea. However, this work was achieved in close cooperation with Northwestern University and is funded by the NIH. 4D flow MRI is a promising imaging modality and a potentially great diagnosis tool. And it has already been successfully applied to studies on intracranial atherosclerosis disease, or ICAT. However, one issue with 4D flow MRI is that it usually requires a lot of post-processing, and this can be very time-consuming. Usually you have to apply some corrections first, for example, an eddy current correction, followed by some noise masking, and optionally even anti-aliasing of the phase difference maps. And actually, Ethan Johnson yesterday had a very nice talk where he showed how all these processes can be automated. Michael Markle also talked about this in the first talk of the session. But we still have the problem, okay, we can speed up the pre-processing, but after we have done our pre-processing, we need to apply a kind of segmentation to separate the vessels of interest from the surrounding tissue and from noise. And still, in a lot of cases, and only after all these post-processing steps, we are able to perform our 4D flow analysis. And still, in a lot of cases, the segmentation is done manually, which is very laborious and can take easily several minutes, and in special cases, even an hour or even longer, especially if you have patients with, for example, stenosed arteries. A possible solution to address this issue is the use of automated segmentation, for example, using deep learning and especially convolutional neural networks. This can, in theory, speed up the segmentation to a couple of seconds. For that reason, the goal of our work was the implementation of such a CNN for the automated segmentation of stenosed vessels in ICAT patients. Here you can see an overview over the network we used for the segmentation. This network was developed by Haben Behain, who actually has a talk later in the session. And this network was already successfully applied to a large amount of aortic 4D flow data, which can be seen here in this paper. And Haben's network consists of a 3D unit. However, Haben added these so-called dense blocks, and in these dense blocks you have a batch normalization, a rectified linear activation function, 3D convolution, and a dropout. For the training, we used a constant learning rate and a constant dropout rate and an Adam optimizer. And for this network, for the automated segmentation, the network expects phase contrast MRA images as input, and as output, the network creates segmentation masks. Here you can see an overview over our workflow. We retrospectively selected dual Wenck 4D flow MRI datasets. All datasets were acquired at the Hospital of Northwestern University. The spatial resolution was at least 1.2 millimeters, and the temporal resolution was at least 86 milliseconds. From these 4D flow datasets, we created phase contrast MRA images, and after that, we used these images for a manual segmentation in Mimics. After manual segmentation, we trained our convolutional neural network, and after the training, we compared the manual segmentation data with the predictions of the convolutional neural network. As validation parameters, we looked at the dice scores of the segmentation masks, as well as the flow rates and the peak velocity values in the large arteries of the Circle of Willis. Here you can see an overview over the cohort we used for the analysis. As mentioned earlier, all data was acquired at Northwestern, and we had 71 healthy controls, as well as 71 ICAT patients. We used a subset of 65 healthy controls and 49 ICAT patients for training, and the training was done on an i9 CPU with a RTX 3090 GPU, and the training took approximately 12 hours. The other 28 cases were used for validation, and we used dice scores, flow rates, and peak velocities as validation parameters. Here you can see an exemplary result of an ICAT patient with a severe stenosis in the basilar artery. And here you can see that the automated segmentation is in very good agreement with the manual segmentation. Actually, in this case, we achieved a DICE score of 0.93. And the agreement is also reflected by this difference map by the green regions. And you can also see very good agreement if you look at the maximum intensity projection maps of the peak velocity values. The next slide shows another case with a moderate stenosis in the left middle cerebral artery. Here it is noticeable that the automated segmentation slightly overestimates in comparison to the manual segmentation. However, we were still able to achieve a quite good DICE score of 0.86. And this agreement is also reflected, this agreement is also reflected by the maximum intensity projection maps. Interestingly, the automated segmentation was able to depict a vessel which was not present in the manual segmentation, as highlighted by the green arrow. Here you can see an overview over the statistic analysis. On the left-hand side is a correlation analysis of the net flow, and here you can see that we achieved very good ICC scores of over 0.93 and slopes very close to 1. In the Blunt-Altman analysis, we saw a bias in the range of 3% and limits of agreement smaller than 22%. The same can be said for the peak velocity values, where we have ICC scores very close to 1 and also slopes very close to 1, a bias smaller than 0.2% and limits of agreement smaller than 8%. This shows an overview over all validation parameters. For the controls, the median DICE score was 0.88, and for the ICAT cases, the DICE score was 0.8. In both groups and for both flow values, we have very high ICC scores and very small bias. However, we observed that the limits of agreement were still smaller in the control group in comparison to the ICAT group. To sum up, we can say that we successfully applied for the first time automated segmentation to a large cohort of ICAT patients. We saw very good agreement between manual and automated segmentation, and we also saw very good agreement of the flow parameters in both groups. However, we saw that the CNN still performs slightly better in the healthy control group, and for that reason we want to incorporate even more stenosis cases in the future. And last but not least, we want to apply the CNN also to other intracranial vessel pathologies, for example, AVMs in the future. So, and then I want to say thank you for everyone who was involved in this project and the audience for the attention.
Thank you for sharing that excellent work. Are there any questions from the audience? Okay, yeah.
Thank you. Interesting paper. Could you tell a little bit more about the manual segmentation? Is this on the magnitude data, the phase data, all the data, and is this truly manual contouring or is it manual thresholding?
So segmentation data was done on PCMRA data, and the PCMRA images were created by actually using both the magnitude images and the velocity magnitude. And yeah, it was a mixture between threshold segmentation and manual segmentation, and everything was done in Mimics, as I mentioned.
Great. I guess is there another one? Okay. Sorry.
I think this is a quick question. Very nice work. Something that caught my attention was that you had an equal number of controls and patients, but for the training, you used an unbalanced ratio. You had much more controls, I believe, than the ICAT patient. Was there a rationale for that, or was that?
We wanted to use a larger group for the validation, but in the future we want to incorporate more ICAT cases to focus more on the ICAT group.
Great, thanks.
Okay, thank you again. We'll move on to our next speaker, Xiuhan Han from Tsinghua University. who'll be talking about TXW ASL, denoising, arterial spin labeling, perfusion MRI with deep learning.
Thanks for the introduction. Good afternoon, everyone. I'm very pleased to have this opportunity to present my research at this conference. My name is Zixuan Han, a PhD student in Tsinghua University. Today, I'd like to share my research on denoising arterial spin labeling perfusion MRI with deep learning method. As we all know that cerebral ischemia is a common physiological process of various brain disease. The severity of cerebral ischemia can be quantitatively expressed by cerebral blood flow. And arterial spin labeling is an imaging technology to measure CBF. It utilizes the inversion and non-inversion of the magnetic vector of blood in the neck arteries to obtain control and label images. By subtracting them, the perfusion-weighted imaging, PWI, is weighted. And from this, we can calculate CBF. And ASL has many advantages, such as being non-invasive, radiation-free, and contrast agent-free. However, the poor SNR of ASL PWI directly affects the accuracy of CBF quantification. To overcome this limitation, ASL typically requires repeated scans for averaging, which prolongs the imaging time and reduces its clinical accountability. So it is obvious to see that there's a trade-off between SNR and scan time. So in this study, we aim to find a method for ASL PWI denoising with the goal of shortening the imaging time while ensuring high SNR. In previous studies, some CNN-based deep learning models have been proposed for ASL denoising. The first two are called ASL DLD and Deep ASL. They are composed of convolution and activation functions of different scales. And the third one is called DAE, which is improved based on the UNet network architecture. And the last one is DL-ASL, which uses two pathways to fuse ASL information. After comparing the previous four models, here I propose a new model called STW-ASL. This model is based on the COMNATS, a classification model proposed in last year. And COMNATS combines the strengths of previous CNN models, and its performance is even better than Swing Transformer, as the figure you can see on the right. And in our models, the network depth has been reduced from 3393 to 1111 to reduce overfitting and gradient explosion issues. And furthermore, in order to adapt the network for ASL denoising tasks, we expand the width of the network while keeping the input and output sizes the same, which allows the extraction of a greater variety of noise features. This page is focused on the experiment details. Our data comes from Camera Tsinghua project, which contains Picasso and M0. There are 52 healthy elder subjects, and we divided 40 cases into training set and the other 12 into testing set. During the data reprocessing, we selected the middle 9 layers where the brain structure can be clearly seen. We use a 10-time averaging PWI as input and the PWI30 mask obtained by segmenting the 30-time averaged PWI through scale stripping technology as a gold standard. After the model completes training, we use MSE, SNR, PSNR, and SSIM to evaluate the PWI denoising results of different deep learning networks. We also calculate the CBF value on the testing data sets. After the CBF calculation, we did some statistical analysis. First, to measure agreement, we calculated the SEC between CBF10, CBF denoised by the STW-ASL, and the gold standard CBF30. Secondly, we use Bland-Altman to measure the bias and confidence intervals. Now let's see the results. The table shows that compared with other methods, we mentioned the proposed STW-ASL, which is our model, shows significantly improved ASL PWI quality with lower MSE, higher SNR, PSNR, and SSRM. And this page shows 2 layers. The far left is the network input, and the middles are the PWI denoised by different models, and this column is our model, and the far right is a gold standard. We can see that the CBF denoised by our method STWSL was more structural or similar to the gold standard. And from ICC and Bland-Altman results, we can see that compared with CBF10, there was a higher agreement as well as a smaller bias between CBF STWASL and the gold standard, which indicates that the CBF after STWASL denoising has a good clinical usability. So in this study, we propose a model called STWSL and show the superior performance in ASL PWI denoising. The CBF after denoised by STWSL shows high agreement with gold standard, which means that our method is clinical usable and has a potential to reduce scan time and improve SNR. Besides, the denoising model is of great significance for high-resolution ASL and multi-PLD ASL denoising. In the end, I'd like to discuss the limitations of our study and propose future directions for improvement. Firstly, our sample size was small and we lack patients with significant CBF decreases. In future, we aim to include more cases and patient data to enhance the robustness of our findings. Additionally, we observed slightly blurriness in the denoised images compared to the gold standard. To address this, we plan to introduce structural parameters, increasing the use of perceptual loss to improve image clarity. Furthermore, we will use T1 weighted images for quantitative calculation of cerebral blood flow in each brain regions. So that's all of my content. Thanks for your kind attention.
Thank you for sharing that wonderful work. I can start with a quick question. How long did it take to train your model compared to the other models you were testing?
Our model, the training time about, and we use 300 epochs, so maybe about less than 3 hours. And it is shorter than other methods.
Great. Oh, and then, yeah.
Yeah, I just have a quick question to clear up some of the details. Why do you use like 10 times average as the PWI 10 as the input of a network and the 30 as the reference standards? Like how much time in reality does it going to help reduce?
Thanks for your question. Actually, we have tested 5 times and 15 times averaging, but in my opinion, the 10 time averaging is structural similarity to the gold standard, and its scan time can be improved. So I selected the PWI 10 as an input. And usually scan time of ASL is about 5 minutes also. And our method takes 1/3 of the Euro scan times, and which, as I see in the future directions, this may be more beneficial in multi-PLD ASL, which scan time may be longer than half an hour, so the beneficial can be clear, say, maybe in high-resolution ASL and multi-PLD ASL.
Yeah. Thank you.
Great, thank you again so much. Next, we'll move on to Justin Baraboo from Northwestern University, who will be speaking about deep learning, augmented LA, and LAIA segmentation of AF patients.
Thanks for the introduction and letting me be here. I have nothing to disclose. So atrial fibrillation, or AF, or AFib, as I may call it throughout this presentation, is the most common sustained cardiac arrhythmia. Its most serious consequence is stroke, and it's a major contributor to this due to thrombus formation in the atrium or appendage, it breaking off and going to the brain. Now, when it comes to AF management, we try to use anticoagulative therapy to mitigate this, but that carries its own risk of bleeding, so we score systems like CHADS or CHADS-FAST have been utilized, and to treat AF itself, catheter ablation has been utilized as well, And we're hoping to use 4D-Flow to quantify stasis and peak velocities and elucidate some of these phenomenon, particularly to help quantify stroke risk and determine what happens after an ablation. So 4D-Flow MRI allows us to measure the blood flow in a region, and from this we can calculate, or in order to use this, as Michael showed earlier, we need to segment the region of interest. And so for this, it's going to be the atrium and the appendage, which we segment off of a phase contrast angiogram. Using this, we can finally do flow visualization and quantifications and utilize 4D-Flow information. However, the giant bottleneck is that this segmentation takes a very long time to do. For an experienced observer, it can take up to 45 minutes to segment the atrium and the appendage. And so we want to be able to do this faster. And to really put context into why I'm looking at this project, is we have a massive 4D-Flow project looking at ablation pre and post with 4D-Flow MRI, where we're doing this in 300 AF scans. And so we showed some of these results at ISMRM, where you can see a baseline scan prior to ablation on the left and a 6-month follow-up on the right. And you can see that in the atrium, there's much faster flow and vortical flow. So there's a lot of information that we can use if we're able to process this data. So for this project specifically, we've analyzed a little bit over half of the data, but we still have more to go. And we want to know, can we use AI to sort of speed this up? So it comes to no surprise that convolutional neural networks are great for segmentation, as we've seen them throughout this conference and others for a lot of structural segmentation. And Michael touched on that we can do this for aortic 4D-Flow segmentation from Hobbins method. And Patrick just talked about how we can do this in the neurovascular as well. So I want to talk more about what's unique about my data of how we are looking at the atrium. So the velocities, especially in patients with AFib, are much slower. So we have lesser contrast on our phase contrast MRA. The appendage is small and has variant morphology, so it's going to be harder to learn how to segment the structure. And then finally, it's a minefield, as we're surrounded by high velocity structures. As the clipping into the aorta, main pulmonary artery, our ventricle introduces a lot of high flow regions. So what can we do with our network once we've trained it? Well, if we have great performance, we can do automatic volume and hemodynamic quantifications, which allow us to complete the project pretty fast. But with poor network performance, it's not a complete loss, as it might be a great starting point to use for the segmentation. So the purpose of this is exactly that. Can we do a standalone segmentation of the atrium and appendage? And if not, can we augment our manual segmentation pipeline by using the AI as an initial starting point? So for the cohort, we had 114 AF patients undergoing pulmonary vein mapping, where 45 of them were also scanned 6 months later so far, giving us a total of 159 scans. Here is our 4D-Flow parameters, mostly noting that we have arrhythmia reduction. So we take these 159 total scans, we subgroup this into 114 data sets for training and validation, and then moved on to having 12 of these for testing data sets. Then at this point, we started using the network as the initial starting point and using an observer to go and edit these afterwards for 37 data sets. So we used a 3D dense UNet structure shown here, where the input is going to be the 3D PC MRA, and we're going to output the atrium and the appendage, which you can see here overlaid on top. For the purpose of this talk, I'll also show it as just volumes like this, so we can kind of see regional differences pretty fast between the two methods. So for quantifications, we first looked at DICE and volume assessment to see regionally what's happening between the manual and the AI. And then using the velocity information, we can look at the peak velocities in the atrium and the appendage, as well as how slow the blood flow is by looking at the stasis, which is the percent of cardiac time less than 10 centimeters per second, and averaged over the volume, where a higher stasis could be slower blood flow, which could indicate higher stroke risk. So here are our results for the test set of those 12 cases, where I'm showing the best, median, and worst case for the LA and appendage on the other side. Note these are not the same patients as we go across, where the manual is in blue and the AI is in red. We had a median DICE score of 0.84 with interquartile round shown here for the atrium, and 0.47, so a lesser result at the appendage. One thing I want to point out in the appendage is even though it's not getting really the right shape of the appendage, it's in the right location. And it takes a long time to really find the true location of the appendage and start the segmentation there. So this actually might save us a lot of time. So just to show you kind of what this also looks like, here's what the median LA output is from the AI, where the atrium is in red and the appendage is in blue for the median case, which has pretty good performance. And then finally, we had an inter-observer study from a previous study where the 4D-LA had a 0.81 dice score, so we're pretty much at enter-observer, where the main differences really are at the pulmonary vein ostium and the valve. So for our flow results with this, I'm going to show you the bias and limits of agreement for each of the atrium's flow metrics, where we saw a significant bias for peak velocity and stasis in both of the structures, but we saw actually pretty narrow limits of agreement for peak velocity and stasis, indicating that the atrium itself might be good to go already, but in the appendage we saw pretty high limits of agreements, suggesting that it's not ready for that. So moving on to the augmented pipeline, we saw, here are the results, again showing you the best, median, and worst cases, where we saw an improvement of other dice scores between the manual observer, who is now editing the initial training, where this might be because he's more agreeing with the AI and seeing that. I also want to point out the major thing is that the time taken has decreased significantly. We used to take 45 minutes to be able to do this, and now it's only taking 20 to 25. And then in our worst case, we actually had a complete failure where it didn't really find the atrium so much, and it clipped the LVOT. So then we look at its flow results, we'll see that the LVOT clip actually greatly increased our limits of agreements as it's here, but we still see a significant bias in the peak velocity and stasis, and negating the outlier from the complete failure, we would see similar results that we saw in our testing set. So the manual editor who's going in is actually adding the flow regions that he might have done with the de novo segmentation. So to conclude, we were able to use a 3D dense unit network to segment the LA and appendage and 4D flow, and our initial testing demonstrated that we had strong LA segmentation results where the stasis and peak velocities agreed very well with the manual observer. The network was then used as a initial starting point with processing, where the big thing was that the manual segmentation time decreased significantly, speeding up our processing. The limitations for this study is really that it's a single site, single protocol, single vendor experiment, and kind of that the velocity information isn't really directly utilized within the learning process. So with that, I'd like to thank you for listening and my collaborators. Thank you.
Wonderful. Justin, do we have any questions from the audience? Here you did the segmentation of the LAA and LA together. Is that correct in the AI?
Yes, but they're outputted as separate masks, so you can look at them separately.
Okay. Would it be helpful? Have you tried doing each one separately?
I haven't, but I could try that. I think having the LA and the LAA together helps contextualize, especially for finding the appendage. But that could be something to investigate.
If there's no other questions, we'll move on to the next presentation.
Thank you.
Next up, we have Mitsui Miyazaki, who will be presenting about non-contrast MR angiography and nenography, a quick and accurate tool for visualizing iliac vein compression syndrome in less than 10 minutes.
Thank you. My postdoc, Vadim Malis, couldn't make it, so I'm presenting for him. Unfortunately, he made it this presentation for 5 minutes, so I will speak very slowly. May-Turner syndrome is showing here that described as a condition when the left common iliac vein is compressed against the lumbar vertebrae by the overlaying of right common iliac arteries, which can result in substantial complications such as deep vein thrombosis. May-Turner syndrome is rarely diagnosed, yet studies have demonstrated its presence in over 20% of populations. Typically, evaluation of patients with May-Turner syndrome comprise of CT venogram and the venous duplex ultrasound. However, both methods have their limitations, such as result of CT venogram are very highly dependent on their cardiac output, size of the venous line, concentration of contrast agent, and especially in abdominal region. Moreover, CT venogram is very subjective to the safety concerns due to the long radiation exposure, because we have to wait until it comes to the vein. And high dose of contrast medium is very required for the abdominal scan. Ultrasound is constrained by the deep location of iliac veins. So recently, several studies have demonstrated studies using the MR venogram. And we just use our existing method, such as time of flight and the fresh blood imaging to overlay those area and then observe this condition. So the method is showing here, 4 male volunteer scan on a clinical 3T magnet. Image were acquired with using the body and spine coil. The scanner parameter was comprised with 2 methods. First one is non-contrast MR angiography using the fresh blood imaging. The second one is just time of flight. And MR venogram was utilized to the time of flight. Okay. Scanning parameters are showing on the table. Image volume were geometrically matched, and the filter with filter aligned with the booster contrast for the vessel size structures, and then 3D visualized. On the left, showing time of flight, coronal lymphomative images of normal appearance subject and the irregular appearance subject. On the right side shows from superior to inferior, from abdominal aorta to iliac vein separation. The subject A shows the normal appearance iliac bifurcation. And B shows the compressed signal over here. So we study with this and combine with the MR angiogram using the fresh blood imaging of a non-contrast technique. Here is MRA on the top, MRV on the bottom, and combine this, you can see the normal appearance of artery in the vein. On this subject B, showing the compressing by this artery and showing the less signal intensity of the vein. Concentration of a combination of non-contrast MR angiogram and venogram offer alternative to the gold standard of ultrasound and contrast and CT venogram. Advantages are non-invasive, non-radiation, non-contrast of MR angiogram and MR venogram. Provide a high level of details and more robust in capturing condition of those deep veins. The challenge are sometimes the turbulent flow makes that the vein is very obscure to depict. And scan time can be reduced further using alternative case-based fitting. Non-contrast MR angiogram and venogram technique for visualization of common iliac vein compression was demonstrated. Further study are required to optimize the condition and each different situations. References are shown here, and this study was supported by NIH and Canon grant. Thank you for your attention.
Great work. Are there any questions? Go ahead.
That's very interesting. Martin Prince showed some interesting results on the similar at a recent SMRA, and I wondered, all your patients were scanned supine. I wonder what your results might be if you scanned them decubitus or prone.
We didn't scan, we scanned supine position.
Yeah, I wonder whether you might see if you put them on their side, etc., that actually you won't see so much compression.
I see. And also that we are thinking to study using the expiration and inspiration difference. Sometimes compression may be different.
Yeah, I
But
think
we
Martin.
didn't try for
I think
that.
Martin's published his work, so it might be worth having a look at that.
Okay, thank you so much.
I also want to comment on this. There is a group of Italy, they imaged the venous system in an upright position. There are open MR machines that you can upright, and this is also very interesting. But to my own experience, I never ever image venous system without contrast because of the residual thrombi that can be there, and this influences the strategy of therapeutic consequences. What stand and when and what to do.
Thanks for your comment. We haven't studied anything with the contrast agent. These are the healthy volunteer, and then we see one subject is the appearance of the compression.
Thank you again so much. We'll move on next to Haben Berhane from Northwestern University, who will be talking about deep learning-based super resolution 4D flow MRI.
Thank you. So 4D flow MRI is a comprehensive assessment of aortic hemodynamics by acquiring time-resolved directional blood flow. It is able to provide a 3D visualization of blood and extensive analytics for the characterization of hemodynamic changes. However, both 4D flow data acquisition and hemodynamic analysis can be cumbersome and time-consuming. Current implementations of 4D flow are often hampered by long acquisition times of around 8 to 15 minutes, inhibiting its adaptation to routine clinical imaging. Recently, multiple groups have shown the success in using AI to improve the acquisition of 4D flow MRI. In a study by Faridan et al., they demonstrated the usage of AI to upsample 4D flow data by a factor of 2 using training data derived from computational fluid dynamics. Their work had around a 1 to 4% difference in hemodynamics from healthy controls. Inspired by their work, the goal of the study was to derive conventional 4D flow MRI from data acquired at low resolutions without compromising image quality and hemodynamic quantifications. Rather than aiming to produce high-resolution 4D flow, we sought to reduce the scan time by reducing the amount of data acquired by simulating low-resolution acquisitions. For the study, we retrospectively generated low-resolution 4D flow datasets from fully reconstructed data. The fully reconstructed magnitude and phased images were combined to form a complex dataset, which was then Fourier transformed into K-space. The K-space was then center cropped along the phase encoding directions, zero filled, and inverse Fourier transformed back into image space. In order to assess the AI performance across various settings, we performed different center croppings along the phase encoding directions. We performed a 4 times, 8 times, and 16 times center cropping in order to reduce the amount of data acquired and simulate a low-resolution 4D flow scan. Here are examples of the magnitude data at each of these conditions, with increasing blurriness and loss of details in anatomy as resolution gets lower. The nomenclature used is meant to indicate how many times larger the voxel becomes. So for the first example, the voxels are 4 times larger than the original 4D flow dataset. And this trend is similarly seen in the phase difference images, where there's greater blurriness and distortion in the data, as especially in the edges of the blood flow, as the resolution gets lowered. The super resolution AI framework uses a generative adversarial network, or a GAN, which is composed of a generator and a discriminator, which are trained adversely to one another. For the generator, we use a 3D hybrid density unit, as seen in the architecture on the left, while for the discriminator, the architecture consists of 5 convolution layers. The first 4 convolution layers are followed by batch normalization in a leaky linear rectifier unit with increasing filter sizes. The final layer was a convolution with a filter size of 1. This study used a total of 420 BAV patients acquired in either 1.5 or 3 Tesla scanners. The scan parameters are provided here. Of note is the spatial resolution, which is between 1.2 to 5 cubic millimeters, and a VANC of 150 to 500 centimeters per second. For training, we use 360 data sets, while for testing, we use 60. Separate GANs were trained and tested for each low-resolution data set. The loss function incorporates the generative loss from the original conditional GAN implementation. Additionally, we incorporated a divergence constraint similar to what Faridan et al. did, in which the 40 flow is assumed to be divergence-free, so we performed the mean squared difference of the velocity gradient in order to impose the same condition on the AI upsample dataset. To assess the AI performance, peak velocity was derived from the systolic maximum intensity projections, or MIPS, as an example of the right, while net flow and peak flow were derived using 2D plane analysis, as seen on the left. For each quantification, we measured the ascending arch and descending aorta, and compared using Bland-Altman analysis with the bias and limits of agreement, which was reported as the percent difference from the ground truth. For magnitude images, SSIM values were calculated in order to assess the general agreement. For our results, the median SSIM index of the magnitude images for the AI upsample data provided, in which we saw the median SSIM for the 4 times upsample data sets to be 0.95, the 8 times being 0.88, and the 16 times being 0.86. Additionally, we provided examples of the magnitude images output of the AI upsample data sets compared to the original ground truth 40 flow on the left. And we saw for the 4 times images showing excellent agreement in this example with a SSIM 0.92. For the 8 times, there's a greater loss of details, but overall fairly strong agreement of 0.89. And at the 16th time, there's greater loss of details and additional blurriness, but still overall fairly strong agreement of 0.85. For hemodynamic analysis, for hemodynamic analysis, I wanted to highlight the consistency in the flow patterns in the AI upsample data, in which you see that the original 40 flows on the left, and each of the AI upsample data sets are provided here. This example is an adult BAV patient with a dilated aorta, and in general, the path lines in the AI are consistent with our gold standard. Of note is this helical flow pattern found in the upper ascending aorta, which was able to be reproduced across all of the upsample data sets. For voxel-wise comparisons, the Bland-Altman plots of the VY comparison are provided here, but the table below provides the bias and the limits of agreement for each velocity direction across all data sets. And in general, we saw excellent agreement with the bias of 0 meters per second and limits of agreement between 0.03 to 0.04 meters per second across all upsample data sets. For peak velocities, the Bland-Altman plots across all aortic regions are presented here for each of the data sets, and the table below provide the regional differences. Generally, we saw moderate to strong agreement in peak velocities, highlighting a low bias and around a 10 to 14% difference from the ground truth original 40 flow MRI. While for net flow, the Bland-Altman are similarly presented here for all testing data sets, and we saw much stronger to excellent agreement in net flow with a percent difference of 6 to 11% from the ground truth. Of note is that as the resolution gets lower, we saw a decrease in agreement to where at the 16 times we saw a 9 to 12% difference. And finally, for peak flow, generally we similarly saw strong to excellent agreement in peak flow as we saw for net flow, also with a 6 to 11% difference from the ground truth. And while there's a similar decline in performance for the lower resolutions, we still saw overall stronger agreement, where this time was 8 to 11% difference. And finally, I'd like to highlight our future direction in which we'll attempt to combine this work with our other work, and we're using AI to interpolate the missing velocity vector components from a single velocity direction 3D phase contrast time result acquisition. In this example, the velocity, the Vy and the Vz are entirely AI generated, while the noise vectors are from the single velocity direction that we acquired, which in this case was Vx. This will allow us to reduce the number of overall velocity encodings required to derive a 40 flow data set by 50%. So in conclusion, deep learning-based super resolution showed strong to excellent agreement to conventional 40 flow MRI, providing a preferential avenue to reduce scan time. Future direction is to explore the AI performance on prospectively acquired low resolution 40 flow scans and combine it with other acceleration techniques. Thank you.
Thank you for sharing this work. Are there any questions in the audience?
Very nice work, promising results. Have a here.
Oh, yeah.
Podium. So I was wondering, have you compared the results to basically a baseline performance? In other words, just do basic interpolation and see whether that compares to your AI-generated or super resolution results. I think that would be helpful to gauge the gain.
Yeah, I agree. We had it only for the magnitude images, where we saw better SSIM values using AI, but we haven't done it yet for phase difference images, and then to sort of assess, which is sort of our next step as well. So look at that.
I also have a question. Have you thought about how you would change the prospectively collected data to make it undersampled?
Oh, yeah, we'll probably just increase the resolution we require. Well, you try to keep all the additional scan parameters, the temporal resolution and bank the same.
Okay. If there's no other questions, thank you, Hopkins. And we'll move on to the power pitch sessions.
All right, so thank you for sticking around. We're at the last part of this session, and we'll be looking at four very interesting power pitches. The first one will be given by Masafumi Takafuji. The title of the power pitch is Computerized Classification Method for Coronary Artery Stenosis on Coronary MRA Images using Deep Convolutional Neural Net with Weighting Layer.
Thank you for introduction. Whole heart coronary MRA allows for non-invasive and accurate detection of significant coronary artery stenosis. Nevertheless, the visual interpretation of coronary MRA is constrained by the observer's experience, necessitating substantial training. Recently, deep convolutional neural networks have been applied in many medical image analysis studies. So, the purpose of this study was to develop a computerized classification method using a DCNN for significant coronary artery stenosis in whole heart coronary MRA. This study included 951 coronary segments from 75 patients who underwent post-coronary MRA and invasive coronary angiography. Significant stenosis was defined as a luminal diameter reduction of more than 75% on quantitative invasive coronary angiography. Among these segments, 42 segments had significant stenosis, while 909 segments didn't. Rows with 21 by 21 by 21 pixels centered on 951 coronary segments were manually extracted from coronary MRA image. The orthodox DCNN was composed of two backbone blocks and fully connected layer. The proposed DCNN model introduced a weighting layer between the two backbone blocks in addition to the orthodox DCNN model. The backbone block generated feature maps with the annotated coronary region of interest. In the weighting layer, the center of the row was weighted by the hammered product of the feature map and the weighting matrix. The fully connected layer categorized coronary segment as either having significant stenosis or not. These DCN models were trained and tested using a four-fold cross-validation approach. Let me move the results. Using the proposed DCN model with the weighting layer, the classification accuracy, sensitivity, specificity, and AUC were improved compared to those using orthodox DCN models. In this study, we developed a computerized classification method using the DCN model to diagnose the significant coronary artery stenosis determined by invasive coronary angiography using coronary MRA images. The proposed DCN model with the weighting layer, which analyzes the feature around the coronary arteries, achieves high classification accuracy for coronary artery stenosis using coronary MRA. Our proposed DCN-based CAD system will be the effective tool in aiding less experienced observers to accurately identify coronary artery stenosis in whole heart coronary MRA. Thank you for your kind attention.
Thank you. In the interest of time, we'll skip the questions. So, but I encourage everyone to talk to the authors at the coffee break later. Thank you.
Thank you.
So next power pitch will be given by Dr. Chunchen Zhu on with the title of NNU-NET, Deep Learning with Vessel Information for Intracranial Aneurysm Segmentation of 3D Tough MRA.
Yeah, thanks for the introduction. So my postdoc can't come, so I will present for him. Intracranial aneurysm is a very common disease, and it's important to get a segmentation of the aneurysm. So this study we we use a self-configuring deep learning model and bring vessel information to automatically segment the aneurysm on top of MRA. And the cropping is a kind of commonly used pre-processing method. It can reduce the metrics, therefore reduce the computational complexity, and focusing on the region of interest, then you will avoid false positive of other structures, and reduce noise, and also reduce memory. So that's why we use cropping in this study. And we have several steps for because the aneurysm is only on the vessels. So we do the vessel enhancement, which is bright signal on the top, and then do a OTSU segmentation and detect the regions, and then calculate the points, and then do an automatic crop. And here shows the examples. So we do a manual crop because we know the top, the boundary of the brain, there is no aneurysm, so we do a manual crop, and then we do based on the vessel information, we do an automatic crop. So this is use a public data set of 113 MRA images, and we use a combined loss function and also NNUNet, which was talked previously in the challenge. And here is the results. So the original death is quite low because the aneurysm detection is a very challenging task. You can see the NNUNet only achieve about 0.48 deaths. And then the manual cropped image actually increased a little bit of 0.51. And finally, we use this automatic cropping and increase the deaths to 0.56. So there is about 8% increase. It's still significant. So it's a very simple study. Just show this automatic cropping actually helps this deep learning method. Thank you.
Thank you. Next pitch will be given by Neil Patel from Purdue University on the work of quantifying neurofluid dynamics with 4D flow MRI enhanced by physics-guided neural networks.
Thank you for the introduction. So today I'm going to be talking about super resolving and denoising 4D flow MRI using the temporal characteristics of the vorticity transport equation. And so super resolution problems are inherently under-constrained, but an advantage of 4D flow MRI is that we have the temporal characteristics of the velocity fields. And so our question was, how can we utilize this to better perform our super resolution and denoising? And so one of the thoughts we had was to use the vorticity transport equation. And so we can see that the vorticity transport equation nicely describes how vorticity evolves over time, and we can see this in the case of a stenotic pipe here where we have vortex stretching as we progress towards systole. And so the advantage of the vorticity transport equation is that not only is it temporally predictable, but also it doesn't rely on pressure terms, and if used, it can help produce physically consistent results. And so we've used a network architecture that's based on the multi-level densely connected super resolution network. We've adapted it to the higher dimensionality present in 4D flow MRI data, and we trained on patches of the overall velocity field to focus on smaller and more intermediate flow structures rather than those that are dominated by the overall geometry. In the past, we've shown that divergence is a nice way to constrain our estimations and to ensure that our edge voxels have nice reconstruction performance. But here we extend this previous work to look at the evolution of the time in 4D flow, and we prescribe 3 subsequent time frames and predict subsequently 3 high resolution time frames. And so we've shown some preliminary results in the case of the carotids as shown here, where we have nice reconstruction, especially in the near wall voxels towards the superior aspect of the ICA as shown here. And if we quantitatively look at this performance, we see that that in those time frames that have high overall error, we get nice reduction in those specific time frames as well as uniformly throughout. And so you can see this in the case of edge voxels as shown here, but also this is more exaggerated in core voxels, which you can see at my poster. So with that, thank you, and please feel free to reach out if any questions.
Thank you. Last but least, the last pitch will be given by Bing Wen from Shenzhen Institute of Advanced Technology on the topic of vascular wall plaque classification using convolutional neural networks.
Thank you for the introduction. Hello everyone, I'm so glad to come here and share our research. As we know, atherosclerotic plaques are the leading cause of cerebral strokes, but the process evolution of plaque stability remains a significant ongoing challenge within clinical practice. The purpose of our study is to explore the potential of convolutional networks based on deep learning model for accurate and efficient classification of corporate and non-corporate plaques of the basal arteries based on high-resolution visual images. Our dataset, MR visual images were acquired from 63 patients with basal arterial plaques. A total of 3,134 two-dimensional slices were reconstructed for 24 corporate plaques and 39 non-corporate plaques. The visual of the plaque were manually segmented for training and testing the model. The right side is flow chart of MEST. First, data processing. We got ROI cross-section and conform data argument. Second part is input and model. We prepare 3 types of data, including pre-T1 weighted image and enhanced T1 weighted image and T1 mixed. And we choose ResNet 50 based on convolutional model. Finally, we form the model training and model evaluation. The result, the model demonstrates the high accuracy of 0.92 when applied to wall T1 enhanced image. Using only pre-T1 W image with image result in an accuracy of 0.68. However, by combining the 2 data sets, the accuracy improved to 0 to 80. In conclusion, our study proved that classification of basal arterial plaques using convolutional neural networks is feasible, and enhanced T1 weighted images are obviously more useful for plaque classification than pre-T1 weighted imaging. In future work, we will try add some structured data to model in order to improve performance of the model, and we will try obtain more types of visual data and conduct more experiences. That's all. Thank you.
So this concludes our session on AI and vascular imaging. Let's give a round of applause to all the speakers for their excellent talks.